Hello, welcome to Atropia Medic School. We're going over 5 high-yield asthma questions for EMT and paramedic students. Let's get started. So first question, you are assessing a patient with wheezing bilaterally when you auscultate the lungs. Which structures are being affected? A, trachea, B, bronchi, C, alveoli, or D, the pulmonary arteries. So let's take a moment to think about our answer. And if we picked the bronchi, you would be correct. The bronchi are your main airway pipes, if you will, that one primary bronchi goes to each lung. They break off into secondary and tertiary bronchi. Eventually, those bronchi start branching off into little pipes called the bronchioles. And eventually all those bronchioles terminate into millions of grape-like sacs called the alveoli. Now, some basic pathology regarding asthma. What's going on is there is an immune response that's causing your bronchi to constrict down. Your bronchi have a lot of smooth muscle in them. They also have a mucosal lining. So very common for asthmatics to experience this bronchoconstriction, which we will hear on auscultation as wheezing, along with increased secretions. Think of it as kind of a defense, an overblown defense mechanism against something we're inhaling or some sort of trigger. And there's all sorts of triggers out there. It can be environmental, it can be allergies, stress can do it. So there's a number of reasons why this can happen. One thing I want to note here is that asthma is very much we'll call it an expiratory or an exhalation issue. Let's call it an exhalation issue here. What do I mean by that? So when the bronchi get constricted, what's the bigger issue here is that they can't get air out. It's not so much that they can't get air in. Yes, it's going to be harder to get air in, but because we're trying to blow through smaller pipes on the way out, remember when we inhale, that's an active process. We're using muscles like the diaphragm to get air in the lungs. When we exhale, it's normally a passive process. The lungs are very elastic. They just recoil back to their original shape. So when we're trying now to force air out through really small pipes, and as maybe you've done previously with a straw, trying to blow through a really small straw bubbles into water or something really, really hard. A bigger straw, it's much easier to do. So with asthma, one of the biggest issues is that these patients can't get air out. They can, to at least a degree, get air in, but it's going to be a much longer exhalation. And that's why we run into a lot of the issues that we do with asthmatic patients from that bronchoconstriction. They just can't get air out. They trap air in their lungs over time. Anyways, I just wanted to review that there. Let's move on to the next question. A 10-year-old patient complains of difficulty breathing. You note a prolonged exhalation and intercostal muscle use. The vital signs are heart rate 120, blood pressure 100 over 60, SpO2 86% on room air, and a respiratory rate of 26. You should A, administer a nasal cannula, B, provide BVM ventilations, C, assist administering the patient's bronchodilator inhaler, or D, administer high-flow O2 via non-rebreather mask. So we'll take a moment to think about our answer here. And if we picked, sorry, wow, I'm not paying attention. We got to pick first D. There we go. Let's pick D. Why do we need to pick D first over C? I almost made my own mistake right there. So it's clear that this patient's experiencing bronchoconstriction, right? We've kind of talked about some of the stuff here. Bronchoconstriction, and they clearly have difficulty breathing. And we can see that as A, they already told us, but they gave us some indications as well. Prolonged exhalation phase, right? We just talked about that. Intercostal muscle use. Normally we don't see the intercostal muscles being actively used when you breathe. Are they being used to a degree? Yes, but you're not going to see it. When we have difficulty breathing, their use is going to become a lot more prominent. Now, we have some vital signs. Vital signs, when it comes to test questions, always tell you you need to do something, prioritize something, or you're not allowed to do something. Let's note here that the SpO2 is 86% on room air. And although we have vital signs to work with, we probably can, surmise this patient has asthma of some variety. We first got to solve the oxygenation issue. I can't move on to the next step until I try the oxygenation issue. Because what if we oxygenate him and he gets better? Do I really need to start pumping him full of medications? Probably not. So it's not that C is a bad answer. It really is not a bad answer. We can tell here this patient's got a pretty good respiratory rate. They're, when they say that they're complaining of difficulty breathing, it's pretty safe to surmise that they're probably mentating. So we don't need to BVM ventilate them. We know that the nasal cannula, when we have clear signs and symptoms of respiratory distress, probably won't cut it. So let's just jump to the non-rebreather mask. And if that doesn't work, okay, you know what? Let's think about giving him some medication. Nice. All right, so let's move on to the next question. Oh no. All right. Which of the following is not a common side effect of albuterol? A, blurred vision, B, anxiety, C, palpitations, or D, tachycardia. Let's take a moment to think about this. And final answer, hopefully, is A. So let's do a little pharmacology about albuterol. So albuterol is a beta-2 receptor agonist. And what that means is it's activating beta-2 receptors in the bronchi. You can remember this pretty easily by beta-1 is in the heart, 1 heart, and beta-2 is in the lungs, 2 lungs. Now, this is a part of our sympathetic nervous system functions. Sympathetic nervous system. And when we activate these receptors, and it can be activated a couple ways, this is not the only way this works, we're going to get that bronchodilation. So when we activate beta-2 receptors in the lungs, agonist activates, we're going to get bronchodilation. Hence why we like to use albuterol for asthmatics, because by forcing that bronchodilation to happen, we kind of solve the underlying issue. Bronchoconstriction, counteract that with bronchodilation. So, with that in mind, what are some side effects we need to be aware of? SE for short. Well, because we're activating the sympathetic nervous system, and although it predominantly wants to bind to beta-2 receptors, do realize that it will get absorbed into the bloodstream. It will bind to some beta-1 receptors in the heart. And that's why we're going to get the increased heart rate. Consequently, that will also increase the blood pressure, because if I make the heart do more work, blood pressure tends to go up. Some patients may complain of the palpitations, right? Because we're making the heart do more work, palpitations. And in older patients who maybe have not just respiratory issues, but underlying cardiac disease, we could see chest pain. Not super common, but it's something to be aware of in someone who may have a more stressed out heart. This doesn't mean that we're not going to give this medication to someone who has underlying heart problems. That's not necessarily the case per se. We just need to maybe monitor someone more closely if they have asthma and they have like coronary artery disease or something. We'll monitor them more closely. Because we're activating the sympathetic nervous system, fight, flight, or freeze, what's something we might experience if we have kind of that like very visceral reaction? Anxiety. So anxiety can be one of the side effects that a patient experiences on albuterol. Now, what are some true contraindications? Well, obviously a true allergy. If the patient's truly allergic to this medication, obviously we're not going to give it to them. But one thing sometimes that comes up in questions is if they give you a heart rate that's somewhere, some textbooks say 130, some textbooks say 150, but definitely if you see like a wickedly inappropriate heart rate, like they say like 180 or 200 or something like that, we should recognize that, okay, you know what, they may have wheezing, but there's something else going on here. There is something called cardiac wheezing. We can see some issues with the pulmonary blood vessels in cardiac problems that can induce wheezing, and it's not necessarily due to asthma. So do realize that that's a thing. I'm not sure if you would actually see a question like that on the test, but do realize, like, if we get a heart rate like what, that's clearly inappropriate for the patient's age and what's going on. We need to maybe consider, is this a different issue? Maybe hold off on this medication, because again, it will increase their heart rate, will increase their blood pressure. It might make some of their other symptoms worse at that point. Alrighty, let's look at the next question. All right. You have a patient in asthma exacerbation. You note bilateral wheezing on auscultation. The vital signs are heart rate 90, respiratory rate 24, and labored. Blood pressure is 130 over 80. SpO2 is 92% on O2. You should A, administer epinephrine 0.3 milligrams 1 to 1,000. B, administer positive pressure ventilations. C, administer CPAP. Or D, administer a beta 2 receptor agonist. So take a moment to think about your answer. But I think we can all conclude that D is probably the best answer. We just talked about albuterol a little bit, so you can go reference that on your own if you need to. Reason why here now we're going to pick albuterol as the answer is, note how our SpO2 is 92% on O2. So we've given them the oxygen. We are at least trying to address that. And it's not doing exactly what we want to do. It's clear that this patient is still symptomatic. They may even mention it over here. Respiratory rates 24 and labored. I know there's no age. Don't really care. Labored is labored. Don't read more into it. So at this point, we've already tried, oxygen. Not cutting it. Next step would be to do that bronchodilator treatment. Now, note that they use the words beta 2 receptor agonist. They may not flat out say albuterol. They might say bronchodilator and things like that. They may even say sympathomimetics sometimes. And this is just different ways of kind of talking about, I want to give a medication that achieves these things. They may not flat out say albuterol. They may very well, but they may not. They may say beta 2 receptor agonist or adrenergic agonist. They may say bronchodilator, sympathomimetics, things like that. Be aware of it. Now, for EMT purposes, A is not going to be our preferred way of doing this. This is really more for anaphylaxis. Now, at the paramedic level, I will mention this, and actually in more and more state protocols, in a lot of places, even EMTs are being allowed to do this. Epinephrine does function as a bronchodilator. So we may sometimes do this in certain situations where someone has severe asthma and is not responding to bronchodilators. But this is not an NREMT thing. Don't think about this for the NREMT. That's more of a local or state protocol thing. But do realize and study up on your protocols if you're allowed to use epinephrine for refractory severe asthma. Anyways, administer positive pressure ventilations, respiratory rate of 24. That's within our okay range. Yes, they're tachypnic. No, we don't need to BVM ventilate them. They don't tell us anything about, diminishing mental status or any of our common language for respiratory failure. CPAP, would this be a potentially good option? It might be. I'm not saying no. I love CPAP from my 10 years in EMS. But why jump to CPAP, which can be sometimes a little tricky to use in patients because we have to coach them into it. They can't be hypotensive. They have to follow commands, things like that. I would jump to CPAP third at that point, right? Because if I solve it with just a bronchodilator, if I just gave them albuterol and they felt better, cool, awesome. I didn't need to pull out the CPAP and go through all of that. But don't be afraid if your bronchodilators aren't doing what you want them to do. Maybe we need to jump to CPAP. Maybe we can even do the albuterol treatment through the CPAP because a lot of them can do that now. So let's just first start off with the bronchodilator and we'll move on. All right, last question here. You have a patient with difficulty breathing, mild wheezing, and palpitations. They are pale and diaphoretic too. The vital signs are heart rate 170, blood pressure 86/60, respiratory rate 28, and SpO2 of 95% on O2. You should A, call for ALS, B, administer an albuterol nebulizer, C, administer CPAP, or D, perform carotid massage. So let's take a moment to think about an answer. And I know we kind of talked about this in a previous video, but at this point, calling for ALS is probably our best bet. Let's go through the other answers and see why. So we mentioned in a previous question, heart rate of 170 is going to be a pretty inappropriate heart rate for someone just having asthma. There's something else going on here. They've got palpitations, combining that with some shock signs, pale and diaphoresis. Yeah, there's something else going on here than just they've got asthma. I'm a little, the heart rate is way too inappropriate. Administer CPAP. We talked about how one of the contraindications to CPAP is going to be low blood pressure or hypotension. So that's out. We can't do that because look at our blood pressure, 86/60. At the EMT level, carotid massage is not a thing that is in your scope of practice to do. As a paramedic, we can do this for some tachydysrhythmias like SVT, but at the EMT level, not really appropriate to do. So at this point, let's call for ALS. We're already doing all the things that we should be doing. We're giving them oxygen. Hopefully we're treating for shock too. All that fun jazz. I hope this helped explain a little bit about asthma. If you like the content, like and subscribe. If there are things you want me to do questions on, feel free to leave a comment, and we'll see you next time.